Okay, this should be the third and the final section of our video presentation for this week in online psychopathology. So now I want to describe the sleep disorders and try to put them in the context of that normal sleep architecture. So let me see if I could list most of them. I may not have them all, but the one that most people think of is insomnia. And then there's a disorder called hypersomnia. So this is not sleeping enough or not getting what's called restorative sleep. And it needs to happen at least 3 nights a week and go on, according to the DSM's criteria, for 3 months. That's, boy, more than I could tolerate. But that's insomnia. And hypersomnia is the reverse. It's sleeping too much. And there's a lot of so these are what are called dysomnias. Dysomnias, in that sleep is not, it's not occurring at the level that it should be occurring for the person. Either they're fatigued with hypersomnia or they're fatigued with insomnia. There are a lot of things that are called parasomnias. There's a whole group in the DSM called parasomnias. Now, parasomnias are really strange. Those are things like sleepwalking, and sleep talking. I don't really think I don't believe that's actually in the DSM. But it usually goes with sleepwalking. And there's something called night terrors. And there's a nightmare disorder. And there's sleep apnea. And I guess last but not least, I should put narcolepsy here. And there are probably other ones too. These are the, in my mind, significant ones. Now, what makes this really interesting is that these parasomnias relate to disruptions in REM and non-REM in a very strange way. Sleepwalking, sleep talking, and night terror disorder. Night terror disorder is where a person wakes up, or is really asleep, but gets up and often starts screaming and could run around the room, and you can't wake them up. They are actually asleep, and they're experiencing some terror. I've actually had a roommate who had it, and it's really profound to see. And then at some point, they get back into bed and fall right back to sleep. So it's this terror where the person actually physically moves around. Sleep talking, sleep walking. Again, it's not a terror, but the person is asleep and they're moving around. Now, the interesting thing is, if you ask yourself, well, do these happen in REM sleep, dreaming sleep, or in non-REM sleep? Well, I already told you that in REM sleep, you're paralyzed. So you can't get up and walk around when your body's paralyzed. So all 3 of these happen in slow wave sleep, stage 4 sleep. It's very unusual, but the person is deeply asleep. And so anyways, these tend to run in families. And the other thing, as you're older, you have less and less of this deep sleep, stage 4 slow wave sleep. So you tend to grow out of all 3 of these in terms of frequency relative to childhood and adolescence. So there's sort of a natural maturation away from these parasomnias, sleepwalking, sleep talking, and night terrors. Now, nightmare disorder, that's another thing. Nightmare disorder is what it sounds like. It's bad dreams. So nightmare disorder is anxiety and fright invoking dream content, and that happens during REM sleep, dreaming sleep. Again, this happens during non-dreaming sleep because you're paralyzed during dreaming sleep. So nightmare disorder is what it sounds like. It's a nightmare. Now, sleep apnea. Sleep apnea, earlier I did all those squiggly lines, but one squiggle I didn't put on there was breathing, respiration. So another thing we measured was respiration. In and out. Breathing, respiration. What happens with sleep apnea is the person actually stops breathing for 20, 30, 40 seconds, up to 2 minutes. And having worked with clients with sleep apnea, it's absolutely stunning to see on a EEG machine because the respiration just flatlines out. And then at some point the person is so anoxic, so low on oxygen that they wake up and they gasp for breath. And then they fall right back to sleep. Most people with sleep apnea do not have memories of waking up. due to the fact that they simply stop breathing. It's pretty profound because I worked with patients, clients, who actually had these apnea attacks where they stopped breathing 200 times in a night. They were waking up constantly. Their normal sleep architecture was all disrupted. And their complaint was hypersomnia. Hypersomnia, that they felt like going to sleep all the time during the day. And so when somebody complains of being fatigued, hypersomnic, and especially if they're heavy set, like me, a little bit older with kind of a loose neck, and they snore. Snoring is a huge sign. If you ask the partner or whatever, if they snore, they may have what's called the obstructive type of sleep apnea, where at some point as the muscles relax in the neck, it actually closes off the airway and stops the person breathing until they're awakened due to the lack of oxygen. So there's obstructive sleep apnea, and there's amnesia for these awakenings. That's what's so stunning. There's also sleep apnea that's due to other diseases and central nervous system issues that's called central sleep apnea. But the one I think we tend to see in practice is more related to this obstruction of the soft tissue in the throat. So that's sleep apnea. And then narcolepsy. Now, narcolepsy, it's an amazing disorder. It's not that frequent. It's fairly rare. But if you yourself experience it, or you know somebody who has narcolepsy, the person goes from being fully awake straight into REM sleep, dreaming sleep. So what happens in REM sleep? You become paralyzed. So what happens to somebody with narcolepsy? They go from being awake to losing all their muscle tone and slumping over and falling down, and they're dreaming. And there's this period, like there is when we fall asleep, where you're partially asleep and partially awake. So they have what's called that hypnagogic, almost hallucination, where as they're falling into dreaming sleep, a person with narcolepsy, from awake sleep straight into REM sleep, it seems like there's visions. It used to get diagnosed as schizophrenia because of these visions as the person's falling asleep. But once we can measure EEG and other things, you can see that the person is going straight into REM sleep, into dreaming. So they're really attacks of dreaming sleep. The other weird thing about narcolepsy is what seems to initiate it, and it seems to be, I'm not clear on whether it's inherited or acquired. I can't really say clearly. I'd have to look that up in the DSM in terms of predisposing factors. But the thing about narcolepsy, what seems to initiate attacks is emotion, any kind of strong emotion. If a person laughs, so working at Stanford Sleep Clinic, if I told somebody a funny joke and they had narcolepsy, and we had them sitting up, they'd fall asleep. Or if a person gets angry, any kind of like emotional arousal seems to click off these sleep attacks. So you can see how this can be interpreted psychologically as some sort of defense mechanism, and who knows, perhaps it is. But it's not like they're starting to be emotionally aroused and they dissociate, or they become conduct disordered, or they do this. They literally a person falls into REM sleep who has narcolepsy. And so it's treated with medications, mostly like Provigil. The other thing is that folks that I've known with narcolepsy can keep themselves very flat emotionally, because there is this awareness that emotional arousal will initiate a sleep attack. So often those people are flat, and it's like a practiced flatness of emotion in order to stop this from happening. So there you have it. These are like some of the parasomnias and sleep apnea and narcolepsy and nightmare disorder, and then these deep sleep stage 4 disorders that you tend to grow out of. And this night terrors is an amazing thing to see. And then back to insomnia and hypersomnia. The thing about insomnia, and I can't cover it all now, but there's books and books and books on insomnia, is that there's a type of insomnia that's secondary to other physical disorders, pain, for example, or just about any kind of illness. So there's an insomnia that's secondary to physical or other mental disorders. And then there's an insomnia that's only secondary to, like, basically stress. And so the older DSM separated those two, called them primary insomnia if it was just stress-related insomnia, or secondary if it was secondary to another mental disorder or a physical disorder. But this current DSM-5 actually lumps them pretty much together as insomnia. And then there's subtypes with psychological or medical co-occurring issues. So it's more of a lumping of all insomnia together. I'm not sure I like that. I like the distinction of primary versus secondary insomnia. Primary being you've ruled out drug-induced, and that there's substances involved. You've ruled out medical conditions and other mental disorders, versus secondary where the insomnia is part of another picture. So now they've been more clumped together with subtypes to specify these other conditions. So that's it for sleep disorders. I think we're going to leave sexual disorders and gender disorders for you to explore on your own, and we'll have a discussion forum question related to probably gender identity disorder, now called gender dysphoria, and some of the other sexual disorders. But let me just say that sexual disorders tend to be in three different categories. They're related to the sexual arousal, either interest or arousal of actually having sex, or they're what are called paraphilias, which are unusual and harmful or distressing ways of being aroused. And that's where you have things like exhibitionism and frauderism, rubbing against people, and a whole slew, pedophilia, of ways of sexual arousal that have negative, serious, most often have negative consequences. And then so there's these paraphilias, which are strange ways of getting aroused, the sexual just sexual disorders of sexual arousal, and then the third category relates to gender dysphoria, with pain and distress around your feelings of your gender versus your sexual physiology. So you'll be reading more about that. So that's it for now. That's quite a lot of information, and I know I've been talking real fast, so I really want to thank you for paying attention to all this, and hopefully I've given you some insight into some eating disorders and some things about sleeping disorders. And remember, if you sleep in, you'll remember your dreams much better. Thanks a lot. Bye-bye.